Well, good afternoon, everyone, and thank you very much for attending. This will be our last series on webinar on the impact of COVID-19 on seniors' mental health. And first of all, I'd like to acknowledge the funder. Wish to thank the Public Health Agency of Canada for the funding that allowed us to produce these webinars. We would also like to thank our partner CHSSN, Community Health and Social Service Network, for their support with this project. As you know, if you've attended our other sessions, we ask you to put your questions as you think of them. Don't wait till the last minute in the chat box. So Brendan will be able to ask the questions of the presenters after each presentation. We're very fortunate. We have two very, very busy gentlemen who are giving us very valuable time to come and address us, and we're thrilled. And first of all, I'd like to introduce Dr. Michael Kanevsky is a family doctor and an intensivist specializing in Integrative and Myofascial medicine, as well as the executive medical leadership and innovation. I apologize for mispronunciation. Medical things is beyond me. During the pandemic, he was named to lead the intensive care unit of the LaSalle General Hospital as chief and medical director. He is also the founder of ConnectIn.io, a digital ecosystem that works to improve health and wellness through innovative methodologies. We refer to Dr. Kanevsky as Dr. K. He likes that, and I'm all for it. Dr. K spent decades practicing sustainable global medicine and community-oriented primary care. Prior to COVID, he acquired epidemic experience in Haiti during the UN cholera outbreak in 2010. Dr. K is passionate and driven about ethical, evidence-based, and non-invasive technological innovations that treat the 21st century individual and system pathologies of isolation, fragmentation, and sanitarianism, while preserving the focus on the patient-clinician relationship, family and community, as a multi-module and effective healing collaborative. Dr. K has a transdisciplinary approach, and he works with students, researchers, healthcare leaders, ethicists, futurists, and key stakeholders in industry, private and public sectors to make health and wellness simpler and more accessible. Dr. K has also co-founded, spearheaded, and launched multiple local and global initiatives for evidence-based, impactful, and sustainable community-oriented primary care interventions, including the United Nations, governments, and communities in St. Kitts, Nevis, Uganda, Haiti, United States, and Canada. Whew. I don't know how he does it all, and I can vouch for it. He is extremely busy. And I do welcome, and I'm looking forward to hearing what you're going to tell us about our healthcare system post-COVID, and looking forward what has worked well, what needs to be changed. And without further ado, I'm turning it over to you directly, Dr. K. And right after his presentation, we will be going to questions for him. Thank you.
Thank you so much. I appreciate it, Ruth. Thank you for the warm invitation and the patience as we get all the slides coordinated. I look forward to having a chance to present, and perhaps we'll start with a bit of a video prior to a couple slides, and looking forward to any and all questions. I'll do my best to help. We can go ahead, Brendan.
Hello, my name is Michael Kanevsky, or Dr. K. I'm a family doc and critical care doc based in Montreal, Canada, originally from New York. Today, I'm going to be telling you a little bit about why the AAHCM invited me to talk to you about teleempathy and how you can bring it home to your community. What is teleempathy? Teleempathy is a way where we can create healing, where we can feel our patients even though we're connected to them virtually, where we can feel the family members of our patients even though they're not physically there. And that connection has to be simple and safe. What we did right before the first wave was we created a system with donations and assistance of large technology companies, as well as coordination and collaboration with our local, regional, and federal health authorities that allowed our patients to connect simply and securely with their family members, while at the same time being able to connect with the clinician, thereby allowing family visits and medical family visits, the simplicity that we have in person translated to the virtual system. That same system allowed us the capability to be able to have virtual rounding. That virtual rounding capability then scaled to be able to be done in virtual rehab facilities, nursing homes, and scaled to the community. We're able to now visit our patients at home. We're able to visit them in the nursing home, and their family is involved in every step of the way. And there's nothing more telling than the smile of a patient who hasn't seen their family member for days or even weeks as they're stuck in an intensive care unit, as we have a virtual family meeting in a simple and secure way. So let's talk about the background a little bit. So what happened was, as COVID was about to hit, I anticipated that we would not be having visitation in our intensive care unit. In fact, I anticipated that we would need a system that allows patients, families, and the clinician to have the very important family meetings that we have in our intensive care unit and in many other transitional care environments, as well as at home, to facilitate understanding what's going on for the family, for the patient. And by having the family member present with the patient virtually, with the clinician present, it creates a profoundly healing environment, and we are able to transition care to the next step. This same system that we developed in our intensive care unit, we were then able to scale to rehab facilities, nursing home facilities, and in fact create a virtual health and wellness village in our community where we can promote wellness, where we can promote health and involve the family every step of the way in a simple and secure fashion. Let's go back and rewind. What is the disease we were trying to treat? What is the problem we were trying to fix? What is the pathology that I observed that we needed to repair? Well, let's talk about two patients, human beings and the 21st century medical system as a whole. For human beings, we already had isolation as a big problem in our communities and hospitals when it comes to patients and our citizens and our seniors not being able to connect with their family members as often as they needed to. Our system, on the other hand, was also profoundly fragmented. You can't get an x-ray from another hospital without putting in a login or making a phone call. Or even worse, the medical record system doesn't talk to the lab system, doesn't talk to the x-ray system. This fragmentation causes so much burnout and resilience destruction for clinicians that we don't have the empathy we should have. We burn out as a result of a broken system. In fact, we know that isolation of seniors, of individuals, increases the risk of dementia and other medical conditions by at least 50%. Isolation causes increased other medical conditions. And the double pandemic of isolation and COVID created profound medical problems. We know that heart disease gets worse, depression gets worse, anxiety gets worse. Quite a few medical issues get profoundly worse when we as social organisms feel isolated. Let's talk about how broken the system is and how that impacts us. We know that a fragmented system, especially for chronically ill patients, causes lapses in care quality and incurs dramatically greater health costs. More importantly, it causes burnout, and that vulnerability of home care workers before COVID is profoundly augmented with the stress of COVID. So we needed a way to fix the isolation and resolve the fragmentation. So voila, we created connectin. Connectin isn't just the largest protein in our body that gives us resilience and flexibility. It's also a cheesy dad joke about all of us connecting in with our family, with our care circle. So, by helping our patients move more through virtual rehabilitation and having a screen in every room where the physiotherapist is able to have our patients move, even if they can't physically come to a patient who has COVID, they can virtually arrive in the room and involve the family in the care and move them more. Also, our physicians can virtually round. We can have a specialist come from another hospital virtually, and it's a permanent setup in our intensive care unit. Every single room has a device, and it's easy for the patients to use, even if they do not have any technological expertise. The goal here is to make it simple and safe. And in the end, we found that a virtual communication infrastructure that's embedded in the intensive care unit is perfect for connecting patients, family members, and clinicians. Whether we're low staff for ICU doctors, they can round from home. Or the rehab specialist needs to be able to come in and do virtual rehab, they can round from home or from the rehab facility. Or whether a microbiologist doesn't exist in our hospital and we needed them to round from another hospital, they were able to round. But the key here is involving family in the care process. That's where the real magic happens. So the question is, how does this apply to home care medicine? Well, we were able to scale our intervention to the community to create a virtual health and wellness village. And the truth is, this is the future of medicine. We know telemedicine isn't going anywhere. However, telemedicine today is broken. It's 20 years old and it needs to go into the future. The way it's going to do that is with teleempathy. Specifically, almost $1 trillion is spent in the hospital. We know that if we keep our patients at home, we can have less hospitalizations, less emergency room visits, less nursing facility stays, and in fact, better care all around, less mortality rates. And quite frankly, home health expenditures at $100 billion are enough where we need to consider how we can optimize that. We involve the family, we have an efficient and easy to use technological interface that is not fragmented. So the question becomes, what are our next steps and how do we bring this to your community? Well, we have to treat this isolation. We have to eliminate the fragmentation. And go ahead, email us, drk@connectin.io, and we will help you bring teleempathy to your community and to help your community have the same connectivity that we were able to create in our ICU, our rehabs, our nursing homes, and in general bringing wellness to the family members and the physicians, the clinicians, and most importantly, making our patients feel like we're there in person, even when we can't be. And that is the teleempathy that is the future of telemedicine. So today, we didn't have a lot of time to go into details, but please feel free to reach out. Please feel free to ask any questions you may have. How does it work? How do I bring it to my community? And I look forward to connecting with you in much more detail. Thanks again. I'm Dr. K, looking forward to helping you out.
Thank you. So at this point, I would like to transition. As you can see, I've changed my hairstyle since a year ago and put on some COVID pounds. That being said, I even now in retrospect have some feedback and criticism of the video that you just watched, because reality is very different from a marketing spiel. And I think that coming back to our priorities, we can go ahead and queue up the PowerPoint. Thanks, Brendan. So a couple things I just want to make very clear is that first and foremost, on the bottom of every slide, given the importance of mental health and given the stigma that mental health has in our community, I have two things before I continue. Number one, there is a suicide hotline. That number is 1-866-277-3553. You can also text 53353 5353. So 3 times 53. That's going to be on the bottom of every slide. Please feel free to write it down. Please feel free to share it. So again, I'm Dr. K, Michael Kanevsky. I'm originally a family doc. Love taking care of my community, whether it's locally or globally. And I say this with a full heart that one of my biggest priorities is to bring the wisdom and experience of everybody watching this to help fix what is broken in our communities. And I think that being a little selfish as a dad of 11-year-old twins, I only wish they had their grandmas and grandpas around as much as they deserve to. And it turns out that perhaps that could help a lot of the isolation that we're experiencing. But I also encourage and appreciate your wisdom and thoughts on some of the topics I'm going to get into a little bit more depth. Because there's no one easy solution to the problems. And I'm going to take the same approach, trying to be cognizant of time, but really discussing the problem or the pathology or the disease and the treatment or solution, or at least starting the conversation of what can we do different and better. So thank you again for coming, and we can go on to the next slide. So when I had the pleasure of first connecting with Ruth, who is just an absolute champion in so many ways, and I feel honored and grateful that you reached out. And what we discussed would be the priorities and the agenda for our chat today are the fact that we really have to address this new reality in medicine. And part of that is attracting and retaining healthcare professionals. And we'll get into what that means. Then overall, there are mental health challenges when it comes to care, whether it's in a long-term care setting, whether it's in a community setting, and we'll get into that. And then you've heard a bit about this idea of teleempathy. Ironically, as easy as it sounds, bureaucracy and tech infrastructure and politics as usual, whether it's in a private system like in the States, in a public system like here, there's always barriers, no matter how good an idea is. So happy to address how we can make things a little bit easier in some respects. So we can go to the next slide. Excuse me for looking up. This is where I have my bigger slides here. So what is this new reality? And I love that Ruth used this term of attracting quotes and retaining healthcare professionals. The truth is we're incredibly attracted as pathologic empaths to the idea of helping others, okay? That's not the biggest problem. The biggest problem is the burnout. The fact that it happened before COVID, but with the gaslighting and broken systems and fragmentation that you heard a little bit about, it got even worse. The data that I'm going to be talking about in the next couple of slides, you'll have to excuse me being a bit of a nerd. I just want to give you my references, was from the United States Surgeon General, Dr. Vivek Murthy, in a publication in New England Journal last year, where basically he discusses health worker burnout and well-being. So I'm going to try to stick to the salience to leave us time for questions, feedback, criticism. But basically, more than half of health workers report symptoms of burnout. And most of us are dealing with insomnia, depression, anxiety, post-traumatic stress, and other mental health challenges. We can go to the next slide. And I thought this point by Dr. Murthy was phenomenal, which is that burnout, or sometimes it's called moral injury, which I really appreciate. Because burnout, it sounds pretty simple. You're exhausted, you're done. But moral injury on a higher level really addresses the root cause, which is I love loving my patients. But if the system is so broken that I cannot love my patients, it hurts me on a moral level. It is wrong that I don't have X to take care of my patients. And that feeling, that disconnect, where one thing is expected of us, but our reality is very different, creates a moral injury. And that is very much linked to burnout. And I think that while I don't have it written here, I find it interesting that that's a systemic problem. So this point that burnout manifests in individuals, but it's fundamentally rooted in the system pathology, is an excellent example of the fact that there's escalating workloads, inadequate support, administrative burdens, and chronic underinvestment. It's not just about working longer hours. It's about the fact that our mission to serve and the resources we're given and support we are provided don't allow us to do our jobs the way we want to. And I was listening to a program in preparation for today, and I thought it was very interesting because the perception of who we as doctors, healthcare workers, nurses, et cetera, are is very different from our reality. Where somebody in a program was mentioning that, doctors have to remember to ask about mental health. Well, the truth is, I got to be honest, most doctors are not forgetting to ask. They know they don't have the resources to deal with the answer, which is a system problem. And it's a little bit heartbreaking. The idea isn't to depress us more. It's just to say that, there's this joke. What do they call the doc who graduates last in their medical school class? Excuse me. Doctor. Now, that's not a judgment on how someone performs academically in medical school, but the point is most of the stuff you learn, you can and will apply. But if a system doesn't allow you constantly to apply the right approach, it's eventually gonna stop being a priority. Okay, we can go to the next slide. We know that over half of nurses and 20% say they're going to be leaving their clinical practice, especially since COVID. The truth is that number is much higher. Okay. And one of the things that Dr. Murphy brought up is that as healthcare workers, we should never go without adequate protective equipment, masks, gloves, visors. I remember a couple incidents early in the pandemic that really frustrated me, to put it mildly, where the hospital was about to get a bunch of money and an administrator, or as we call it in a honest term, a suit and tie, came by and said, "What do you want to spend the money on?" And I said, "Well, in my intensive care unit, we're going to need equipment to protect the staff. If we could get," this is before we knew just how infectious COVID was, "the best protection from small viruses is an air recirculating system." They said, "Okay, sure, we'll look into it." And they had the money. I asked for beds for patients where if I had to flip them on their stomach so they could breathe in really severe, rare lung cases, they said, "Sure, we'll look into it." In the end, you're not going to be surprised to learn that none of those things were provided. Instead, the money was spent on completely useless technology that I won't go into details what it was, but it was not something we were ever going to use or did use. And this is pretty typical of health system expenditures. There's some pretty good data that for every single doctor, there's at least 10 administrators. And when you look at the cost of healthcare over the last century, the amount of doctors has stayed like this. The amount of administrators has gone up like this, and the cost of healthcare has gone up like this. It's not coming from the doctors. So we can go to the next slide. The other thing that we really have to appreciate is the administrative burden that doctors and nurses as well have to deal with. That basically, when I'm in my clinic, I spend at least 2 hours each night, usually when my girls go to bed, clearing an inbox, answering tasks. This is in addition to human email. These are not reimbursed, and it's not about the reimbursement, but this is not something our patients see us doing or know that we're doing. But basically, for every hour we spend with patients, we have to spend 2 hours on a broken computer software that was designed by programmers who don't have background in healthcare. So these are really inefficient systems. And one day when the robots and AI make it easier, it's going to be wonderful. We can become less robotic and be more empathic. But for the time being, this is a huge problem. We can go to the next slide. The other thing is we need access to mental health care for health workers, okay? We're talking about bringing access to everybody, absolutely, but you can't forget the front line. And this may seem obvious, but it needs to be addressed. Next slide. The idea of strengthening public investments in the workforce and public health is also not a new idea. There's a huge discussion about will spending more money on our public system help? I won't even go into those details. I like the term that Dr. Vivek used where he says strengthening the public investments. To me, when you strengthen something, you take out the unnecessary elements that aren't supporting the infrastructure and you reinforce the existing strong ones. So for me, it's not about more money. It's about how are we to best spend the money. So actually, before we go to the next slide, there's a good point here, and I put on my global and community medicine hat for a moment here, where we have to address the social determinants of health. Housing, food insecurity, personal safety. These are key features where we know in an underserved setting in the global South that if we can help a mother have a job, have a roof over her head, her children will be healthier. And this is key. And it was a pleasure to meet my colleague Sam Watts, who will be coming on later, who's going to speak more to that. We can go to the next slide. Thank you. So basically, we need a culture that supports well-being, and it needs to be okay to say, I am not okay. There's a huge stigma, and it hasn't really shifted. We can go to the next slide. I'm trying to stay cognizant of our time here. So now we're going to talk about mental health challenges in general. And again, I'm sorry for using red. I don't want us to walk away sad. I want us to walk away hopeful with ideas and things we can do. But this is not an easy topic to discuss. I think it's important that we recognize that depression can manifest as anxiety and is dramatically worsened by isolation, okay? And when we talk about these things, God forbid, suicide is one of the potential outcomes that has gone up 4 times, okay, in terms of suicidal ideation, thoughts about suicide, dark thoughts. You can phrase this many different ways, but in Quebec, over the age of 65, we have had 4 times the amount of dark thoughts. I thought it was interesting that while the general population of seniors, we are at about almost 6%. In Quebec, it's closer to 8%. Sorry, in Montreal, it's closer to 8%. In the interest of time, I won't get into possibly why, but higher density doesn't mean more connection, is my theory. And we know that with age, depression doesn't show the same as it does in younger individuals with sadness and loss of desire. It can manifest in aches and pains, problems sleeping, more confusion, more irritability. And these are signs that someone might just say, it's just old age. No, not necessarily. So we can't be so dismissive. Next slide. In a study in Quebec that was published in 2010, so you can imagine these numbers are higher, okay? The prevalence of depression, okay, in individuals aged 65 and over was almost 20% for women and almost 10% for men. The discrepancy can be discussed on many levels. There's a bigger stigma for men. Women are more comfortable sharing. So are those real numbers? I'm sure it's underreported for a variety of reasons. There were some other interesting findings at the time that while men may have a greater diversity of ties, they have in general less support than women. Having a confidant or having a good marital relationship was negatively associated with depression in men and women. Let me clarify what that means. That there was less depression for individuals that were married. Negatively associated means less of it. And compared with married people in general, widowhood, no surprise, was associated with a considerably higher risk of depression. I know these things are obvious to us. My point is, whether it's for us or friends, members in our community, looking around, I know there's some groups that are joining us today. If you know that somebody near you is in one of these situations, reach out, please. Okay. One of the easiest things we can do that feels a little overwhelming is just connect with the person next to us, because there's a chance they're suffering, and just talking to them can help considerably. I thought we would all appreciate this, that when compared with non-volunteers, men who volunteered were at considerably lower risk of depression than women who volunteer. Now, let me just briefly enjoy the humor in this. As a dad of daughters, I suspect that if we did more dishes at home and did more laundry, aka volunteer work, we would be happier and less depressed. And that relates to all age demographics for us men. Excuse me for making light of something, but I do suspect on some sociocultural level it's related to busy people don't have time to be depressed. Next slide. Again, probably not surprising when we come to long-term care specifically, Canada has had one of the highest global proportion of COVID-19 deaths among long-term care residents. Correction, I find that to be remarkably surprising in a system that should have public health. We have to take care of our most important members in our community. You have given the most to your community, to your families. It is an absolute crime, human rights violation that this happened in Canada, okay? Other than being upset about it and talking to you about it, I'm somewhat limited other than spreading the word. But this can't continue to happen. And shockingly, very few, in fact, the articles I was reading showed that there were no interventions that focused on mental health implications associated with COVID in long-term care. But given that I participated in a couple and I do know of some, I would say limited or few, but it's not the priority it should be. I'm a minute over my time, so I will try to transition to the end here. The Canadian Academy of Geriatric Psychiatrists wrote up a position paper, and I'm going to go quick through this because I consider this type of research, while necessary and beautifully summarizing things, it is what I tell my medical students is the data. We know this. It's a shame that somebody had to take money and time to publish a paper on it. So here is the data from the Geriatric Society of Psychiatrists in Canada. Mental health care in long-term settings is essential. Okay. Factors such as age, presence of dementia, or diagnosis of prior mental health problems are not reasons to exclude individuals from having access to emergency departments or hospitalizations. The fact that there's restrictions on in-person visits to long-term care must be countered with the potential effects of those restrictions on mental health, quality of life, and dignity. And interestingly, these guys didn't know what we had done with Connectin, but they say appropriate communication technology and human resources must be available to allow communication between long-term residents and individuals located outside a facility. Next slide, please. This is a bit of repetition. So what this first point says is that public health measures that limit access really need to consider the impact on individuals in long-term care. All long-term care facilities must have adequate training, staffing, and resources to address mental health during COVID and other outbreaks. And measures of mental health and quality of life in long-term care must be systematically evaluated and have strategies to understand and remediate the adverse outcomes. What's the problem with all of these fancy, wonderful position statements? You can't expect a third or half of the healthcare workers to do 200% of the healthcare workers' jobs. It's just not going to happen. And the outcomes you're going to have are what we saw in long-term care. So it's okay to expect these things, but you need to provide our system with the tools to do it. Next slide, please. So on a positive note, and this is not, just to be clear, a marketing spiel, because Connectin had to deal with the same bureaucracy that every good idea has to deal with, which is when it comes to technology, lack of Wi-Fi was one of the biggest reasons why we couldn't scale in centers, okay? The idea of involving family with the care process should have been around before COVID. If I'm seeing somebody and they want their family involved in their care, I should be able to hit one single button and their family joins us. That's the idea. That same system should allow somebody who is technologically less skilled to connect with their family immediately. So these voice operated systems where you could say, hey Siri, hey Google, call my daughter, that's wonderful. The truth is these things didn't exist when we started Connectin at the very first month of the pandemic. Now it's no stranger to us. I'm speaking to the converted. I'm preaching to the choir because you guys are all on a Zoom call. So this is not the individuals who need the most help. We do need help. We have needs. We need to connect with our community. We need to connect with our families. We need to connect with the person sitting next to us. And that is that healing, love, that empathy that can help us during these times of isolation. I would say some future steps in the short term that we would need is to reinforce with our local municipalities that have the wherewithal in terms of desire to make change locally, more so than on a provincial or national level, because there is going to be less bureaucracy to cut through, to connect people with either their devices or in person or the telephone as we head into what will likely be another wave. We will also be having, thank you for your help with the slide. We will also be having some work with some really motivated adolescents as they do some community volunteering to bring music and other performances to long-term care and senior living facilities, because, and this is a purely selfish thing, but When I was in high school, we would go volunteer with our choir and sing at the local long-term care centers. And it was a beautiful, magical moment. And there's no reason we can't do that with the technology we have accessible. That doesn't replace the family, but I would say that having a way that somebody can connect easily and simply without having to fuddle with numbers and technology is the answer. So happy to address any and all questions. I apologize, I went 7 minutes over. I'll stop rambling at this point.
Thank you, Dr. K. Very, very interesting, and I can relate to a lot of what you had to say. I really do feel that there's a role for community at large to get involved and support our frontline people who are negotiating contracts, like our nurses, like our teachers. It's fine for them and their unions, but I think the community at large has got a vested interest, and it's time that we spoke up. And I feel I have a granddaughter and a daughter who are nurses, and I feel, and I hear it, it's disgusting that you don't have the tools to implement your skills and your compassion to offer the complete care that you know is required. And the long-term care situation, I've always voiced as criminal. I think there should have been charges. Really appreciate your information, your education, your compassion, and your commitment. And very thankful that you're there, and that I'm sure, and I know from other doctors that you're promoting the cause. So without further ado from me, I believe there's one, possibly two questions that have come into Brandon, and that shows that people understand and relate to what you're saying. And we have to be very cognizant of the time, because Sam does have to leave just at between 2 to 3 and 3. He has to be in another community for another very important meeting on behalf of his organization. So Brendan, I'm going to turn it right over to you for your question that you have.
Thank you, Ruth. So there's actually two questions. They're both related to the application, the teleempathy. So let's just combine them into one, perhaps. The first question was, how is teleempathy different than teleconsultation? Can you explain the difference between that? Hold that before you answer. The other one is, can teleempathy still work on a smaller scale with a selected number of hyper-vulnerable seniors? Over to you.
That's such a beautiful question. Thank you for summarizing the two together, Brandon. Yes, there is a difference. I'll get into that. And yes, it can work. I like that, hyper. So to answer what is the difference, teleempathy is not just the doctor talking to the patient via a virtual connection, be it telephone or video. The idea is clear when we break down what does the word empathy mean. Empathy, okay, versus sympathy, right? I feel what you're feeling, or I aspire to. And prior to this work, at one point, I looked up what existed for teleempathy. And it was actually some researchers where they would hook up an electric probe to one individual, and at a distance, they would hook it up to another individual. And one was getting shocked when the other was feeling certain things. And please don't quote me on the details, but that was the extent of how teleempathy literally had been described. And I actually love that definition, because I need to feel, as your aspiring healer, you know, cure seldom, heal always kind of thing. You know, we may not be able to cure the cancer, but we can heal the suffering around it. For that, I need to feel what you're feeling. So for me to have empathy, there are features of teleempathy that have nothing to do with the moment I'm on with you. For example, I need to have slept. I need to have less administrative burden so I can focus literally my heart and soul to be present with you. Instead of having a 7-minute visit, I need at least a half an hour visit. So those systemic issues or solutions allow me to have empathy. I'm sure those of you that have done a lot of these Zoom meetings realize, how can I be so exhausted talking into a screen? It actually takes extra effort to be present, aware, and involved in a screen. Therefore, I need to have more resilience and more capacity to do it. So that's one side of the tele-empathy. And if it's a bit cheesy, totally guilty. But I'd rather be cheesy than burnt out. The other side is involving family. So imagine my patient, Mrs. Smith, imaginary patient, she's older and she needs help navigating the healthcare system and remembering to do her physiotherapy. If I'm doing a Zoom video call with her or a video call, how does she turn it on? How does she log in? What's the meeting passcode? None of those things existed in our intensive care unit. Our system turned on at the right time, automatically letting Mrs. Smith see not just the doctor from a distance, but her family that had been previously approved through the secure system. So basically, that Brady Bunch of all the different faces is the family, the patient, and the doctor. And it happens automatically. And you can imagine that Mrs. Smith is much more willing to do her physiotherapy if she knows that her granddaughter is there saying, hey, Granny, let's do these movements together for your pain. That is what makes it tele-empathy. We have more of an empathic connection in our community. And look, this is a term where I think it should evolve. I don't think it's a dynamic idea, because this is a new thing for us to be doing, this virtual connectivity. And we need to figure out how we can connect through this in a way that resembles human to human contact. And finally, to answer your question briefly, in a hyper vigilant environment, I think I'm misusing the term, in our intensive care unit, we had individuals, for example, who were intubated on a machine, but they'd given consent and their family needed to see them prior to us letting them go. And transitioning from end stage life is something we do in the intensive care unit. And the family couldn't come in due to COVID restrictions. And by having the connection with their family in that moment, even though it was virtually, at least gave the family some peace of mind and comfort. Other scenarios, the gentleman who consented to have his picture shared, he was in tears because he had been on a machine for weeks and no contact with his family. The machine was removed. He was doing better. And just the simplicity of the phone call. We didn't have FaceTime and devices and all that stuff. This was, imagine, month one of the epidemic in 2019. I was shocked that he was in tears. I mean, we all had tears. So I would say that's one example, but perhaps I'm not answering the question well, so feel free.
I think that's great, and I'm afraid I'm going to have to interject because of time. Dr. K, thank you so very, very much. It's been so informative. We will definitely stay in touch because we're hoping to do face-to-face conferences in the very near future. Viruses go away. And no doubt we've got a lot more to talk about and explore. Thank you for your time. If you want to stay on and listen to Sam, you're more than welcome. If you have a patient waiting, we understand.
Thank you very much to all of you.
Thank you. So right now I'm going to go and introduce Sam Watts, who many of you I know him. You've seen him on the news. Sam serves as the Chief Executive Officer of Mission Bo Akai, Welcome Hall Mission, an organization founded in 1892. And he has an annual budget of approximately $32 million and 220 full-time employees and over 300 volunteers. We all should be so lucky. I wouldn't want the cause, but the work, but the volunteers and money. Dedicated to eradicating chronic homelessness and hunger in Montreal, Welcome Home Mission operates emergency and supportive housing services, a mental health treatment unit affiliated with McGill and the Psychiatry Department of the Jewish General Hospital, a rehabilitation service in partnership with the SUS Centre Sud, and a free dental clinic with McGill University Faculty of Dentistry. Its youth services team manages an innovative program called Cœur à Sœur that provides housing and practical support to young mothers and their children. A seniors program provides support to people who live alone and are in danger of becoming disconnected from health and social services. Sam works in a variety of management roles at a Fortune 100 company in Montreal. He was also an independent team effectiveness consultant to corporations, government, and not-for-profit organizations, acting as a catalyst, facilitator, and executive coach. Sam is the author of Good Work Done Better, a book that proposes new ways of thinking in the community-based nonprofit sector. He's also authored numerous articles that appear in local and national publications, and he is a regular page 2 columnist for the Montrealer. Sam serves on a number of nonprofit boards, including the Canadian Alliance to End Homelessness and LARC Canada. In 2022, he was appointed by the Honorable Amin Hussein to sit on the National Housing Council of Canada. In that capacity, he's been appointed to chair Canada's first ever review panel in the financialization of rental housing. He lives in Beaconsfield with his wife, Susan, a corporate lawyer. He has 2 daughters, one who works in the nonprofit sector and the other is a CBC reporter. Sam, without further ado, it's my delight to have you and welcome you, and looking forward to hearing all the great things and what you've seen and what still needs to be done. I turn it right over to you.
Well, thank you. And thank you for that overly flowery introduction. When I said to my wife that I was going to be speaking to the SAQ, she said, I didn't know you were an expert in alcohol. So then I had to explain what the SAQ really is, other than, a store where we go to buy wine. And I was fascinated by what Dr. K said about the social determinants of health, because it's something that I talk about every single day. And that is very simply that if someone does not have adequate shelter and security of healthy food, that we know categorically, empirically, that they're going to suffer from suboptimal health outcomes. And so the work that we do at Welcome Hall Mission and have done for 133 years here is all around making sure that those social determinants of health can be improved for people who are extremely vulnerable, people who are either experiencing homelessness or who are struggling to make ends meet. Our free grocery stores, for example, serve 10,000 people every month. These are people who are housed, but who struggle at the end of the month to figure out, should I pay the rent or do I have enough money left to buy groceries? So you can go to the slides if you want to, because I want to talk very briefly, and I'll leave a little space for questions as well, about the impact of COVID-19 on seniors. Now, I remember vividly my very first meeting. I was called to the CHSSN Centre Sud on the 28th of February, 2020. It was a Friday. And I remember sitting in a great big room around a table with about 30 other people, most of whom were healthcare professionals. I'm not a healthcare professional, but I'm a leader of a significant not-for-profit agency in Montreal that serves the vulnerable. So that's why I was there. And during the entire meeting, and this only occurred to me afterwards, there was not one single mention of seniors. We put lots of writing on the wall. We were posting notes and stuff all over, flip charts on the wall about what we were going to do. Because at that point on the 28th of February, 2020, we were dealing with this virus that we'd heard about that was in China, and it had somehow migrated into a few cases here and there on the West Coast of the United States and Canada. So that's where we were at in that period of time. So a lot of the meeting was speculative at best. And our thought process was, well, if it does reach here, we don't really know what it is. We better be ready, and we better be starting to make some estimates about how we're going to deal with the vulnerable population. And again, I would come back to my point. The entire 2.5-hour meeting, plus or minus, never a single mention of seniors. We talked about children. We talked about community activities. We talked about hospitals. We talked about the homeless population. I remember writing down in my notes that there was an estimate offered by somebody in the room that maybe 300 or 400 people in Montreal's homeless community would pass away from this virus. In the end, I think we lost 19 people. We lost more people to the opioid crisis than we did to COVID-19. So we all know, and Dr. K touched on it, the almost criminal impact in the CHSSN days with seniors. And I don't think that we're really done addressing some of the challenges, some of the systemic challenges in that system. But I've got a bunch of slides to show you, and I'm going to go through the first 5 or so fairly quickly because they're just photographs. But if you look at the very first photograph that I'll put up here, the doctor talked about moral injury as a function of another way to say burnout. And when we look at what's going on out in the big bad world, what's happening on the streets, what do we see? Well, we see a lot of people who are suffering from challenges. The concern, the challenge of homelessness that we face at Welcome Hall Mission is much more complex than it used to be. And, how do I relate this to people who are concerned about the well-being of seniors? Well, we know from statistical data that the age of the first experience of homelessness is actually going up. Used to be that, generally speaking, someone's first experience of homelessness happened in their late teens to late 20s. And then there was this pattern that repeated itself. We're seeing more and more people now who have their first experience of homelessness in their 50s. And that's a concern. It's a concern for a variety of reasons that I'm not going to elaborate on right now. But Dr. K touched on the fact that seniors are people who have contributed greatly to society. And to me, it's a horrible shame when we get to the point where we're in our 50s or 60s or 70s or greater, and we run into a challenge whereby society is not able to properly have the structures in place where we can get the care that we need. So if you go to the next slide, you'll see that another thing that we see is the crisis around housing and social housing specifically. The next slide shows a picture of a protest where people are saying there's an inequality going on between the rich and the poor. So we're seeing the gift of the North American middle class, which was part of that social contract, if you will, post-World War II, where that middle class continued to be able to afford more and more things. And we're seeing that begin to disintegrate. And of course, that leads to the potential for political populism and somebody to come along and say, well, I'm not going to tell you what the answer is, but I have the answer, elect me, and I'll fix everything. And the other thing that we see, and you'll see it in the next slide, is challenges related to mental health, particularly among the young. But Dr. K touched on it quite eloquently to say that it's also among older people and perhaps far more prevalent than what we see. Because the next slide that I have there, it shows a senior, and we know that isolation was a factor well before the pandemic, and that there are a lot of challenges related to isolation, mental health being one of them, but there's a lot of them. And I love what Dr. K said, that population density does not translate necessarily into better personal and human connections. And we've certainly seen that in Montreal. So during the pandemic, I would say before the pandemic, our free grocery stores did not deliver. So if you wanted to get free grocery stores at Welcome Hall, or get free groceries at Welcome Hall Mission, you had to come physically and take your shopping cart, go around, select your products, and have the experience of shopping. But of course, during the pandemic, we had people who were immunocompromised, etc. And so we decided we would start delivering to those people, many of whom are seniors. And one of the discoveries that we made, which will not shock any of you, is that a lot of seniors, the only human being they saw was us. When we delivered our groceries, and then the next week when we came back again. And it caused us to start a new program, which Ruth alluded to, where we're serving seniors who are getting free groceries from us, but that's not all they're getting. We're helping them reconnect to a network of care, whether it's social services or whether it's making sure that they're hooked into the medical system, the network of medical care, the hospital system, and so on, going to their appointments and so on. So that's a very important thing, and we think it's critical. And you'll see on the bottom of some of these slides, loger, nourrir, aimer, those are our three buzzwords here at the mission: shelter, food, love. And for us, it's just a reminder of our key drivers, sort of the reason why we do what we do, because we believe that everyone should have access to a roof over their heads in Canada. There's no reason in the world why all of us as Canadians shouldn't have some place to call home that's suitable. And nourrir, or food, is all about getting access to healthy food. Canada produces more than enough food to feed everybody several times over, yet 35% of Montrealers suffer from food insecurity, and that just doesn't make sense to us. And the last one, which is about love, is really about being connected to a community of care. So back to the social determinants of health. If I, as an individual, have a roof over my head, if I have access to healthy food, and if I'm surrounded by some people who care about me, maybe not a lot, but at least some, there's a good chance that I'll have good health outcomes. And we know that the opposite is also true. So what are we looking for ultimately? So if you go to the next slide, one of the things that I've said to people is our governments are very addicted to patches. We always have a tendency, because of course governments work on the electoral cycle of every 4 years, and it's easy to come up with something that's going to solve just part of the problem, or that's going to mask the problem. And increasingly what we're trying to promote to our friends in government is the notion that instead of constantly putting patches on problems here and there and playing essentially a gigantic game of whack-a-mole, what we need to do is start working towards permanent solutions that may take a little bit of time to implement, but if we start in the right direction and we continue to promote these solutions, we continue to fund things that are going to lead us to a solution, that we'll actually get to where we need to go, as opposed to putting patches on and hoping for the best. So it leads me to the question, which I suppose I'm tasked to answer here, which I'm going to do in the next slide, is what worked or emerged during the pandemic? What did we discover during the pandemic? And so I got a couple of things here, and this is probably the slide with the most writing on it, but the first major thing that we discovered during the pandemic, I'm not going to spend a lot of time on it, but there was this failure to implement the existing medical protection for senior care. You might be surprised, or maybe you won't, to learn that there was a plan in place that existed for the CHSSN days. There was a plan for long-term care. It's just that nobody implemented that plan. And so when the failure happened, the failure was compounded by a series of bad decisions and bad choices. And so there were tragedies and there was issues, but we still haven't resolved the challenge of underpaid, underqualified staff that exist in many of these facilities. And some of these facilities, you may have read in the news this week, a story that my youngest daughter posted about a facility up in Quebec City that has one washroom for 43 residents there. And that's the sort of thing that you don't need to be an expert in any kind of care to know that that's simply not workable. We know that some new services have emerged to try and deal with mental health and mental health challenges among seniors, but I think that's still something that the book is not closed on. But I always like to switch to being an optimist and say, what were the good things that happened? Well, I think one of the good things that happened was we have a more profound understanding of the need for emotional and mental connectedness than we might have had before the pandemic. So to some extent, the pandemic was not all bad in that it elevated this awareness that maybe didn't exist as much before. And I think the other thing is that we have come to recognize that secure, permanent housing matters. And even I go as far as pointing out that with climate change, we need things like air conditioning and HVAC systems to be properly installed in apartments and in places where seniors are going to live, because every time it gets hot outside, it's so hilarious. The media gets all into a frenzy and they come and see me and they interview me. And it's always the same question about people on the street. What about the homeless, Mr. Watts? What about the homeless? Well, you know, the homeless in the context of a heat wave in Montreal are actually relatively well cared for. But people who are living alone in an apartment building, who are older and who don't have air conditioning, they're in a much more vulnerable state than somebody who might be living rough on the street or somebody who might be accessing an emergency shelter. So it's important. And I think the other point that I made, the third bullet point here, is the idea of affiliation, connectivity to the healthcare network. Whenever someone is disaffiliated from the healthcare network, isn't going to their appointments, doesn't have proper access, we know that something's going to go wrong. Something at some point is going to be less than ideal. And so that becomes a critical thing. So in the next slide, I love the sort of the visual that I've got here of the heart, because I found the presentation by Dr. K was one of those things where he demonstrated a ton of empathy. So his topic and who he is aligned very nicely. I think, you know, a lot of times we can boil the healthcare system down and the needs post-COVID to a series of bureaucratic things that need to change. And I don't deny that. Certainly the point that he makes about way too many administrators in the hospital system versus doctors is one that I relate to totally, because we deal with the healthcare system all day, every day. And it can get pretty frustrating, particularly dealing with people who have developed a talent for making sure that they can tell you that it's not their file that is on the desk. It's somebody else's responsibility. So with multitudes of administrators, there tends to be this ability to pass the buck and play hot potato with issues. But I think what we have to do is we have to develop this objective. In fact, one of the things that I contend is if we work to reduce poverty and to ensure social connectedness, we will actually improve healthcare without necessarily doing a whole lot of other things. Now, I'm not saying that we shouldn't improve the healthcare system. I don't want to be quoted as saying that, because there's a ton of opportunity for improvement inside the system, and Dr. K touched on just a few of those things. But imagine if we had fewer poor people in the city. Imagine if everybody had some degree of social connectedness. If we all had some friends and family who would care for us. When people ask me about people experiencing homelessness, and we care for hundreds of those people every day, they ask, why is it that people fall into homelessness? And there's a whole variety of reasons, but there's one common thread: social disconnectedness. If I were to find myself in difficulty, I would hope that one of my friends or my family would come around and would take care of me. But if you don't have friends or family, or if you burn some bridges, very difficult to make sure that you get the care that you need when you're in a tough spot or when you're by yourself. So I thought about what's some things that I could offer to this illustrious group of people who are being compelled to listen to me. And so on the next slide, I've kind of got three elements that I think are essential if we're looking for systemic change, because Dr. K was certainly talking about systemic change. And I think the first thing is to have better knowledge. I think we're only beginning to understand the problem of social disconnectedness. A lot of people still think people who end up in difficulty, whether they're seniors or whether they're others, that they have something to do with that, like it's their fault. And in some cases, yeah, people might have made suboptimal choices, but that's not the point. What we need to do is we need to understand the roots, the causes connected with social disconnectedness. And then the people who can change things have to feel like that matters. Because if they know about it, like a lot of times I've found that people can intellectually know about something, but not get to the point where at a heart level, they care about it. And so to convince people to make the right decisions, to convince people to put the right structures in place, to convince people that our senior citizens deserve the kind of care that they have earned because of their contribution to society, we're going to need to make them feel like the knowledge that we can present to them, the facts that we can present to them matter. And then we actually have to come up with credible solutions. We have to come up with the kinds of things that are workable, that are doable, that are possible. And the good news here is that in many cases, we already know what they are. And what we have lacked over the last little while has been the political courage to actually do them. And I think that's going to be something that we're going to be looking for in the next little while, is do governments have the political courage to take the steps to put the money in the right place and do the right thing. I liked Dr. K's analogy about strengthening the core, because ultimately, when you're trying to fix something that's not working, it's not a matter of throwing more money at it. In fact, sometimes in our sector, I'm not convinced that more money is the solution. I'm convinced that better spending of the money we have is the solution. So if you go to the next slide, I think we need to put the pieces of the puzzle together the right way. And one very practical suggestion that came out with Dr. K's presentation, it was just about men, but volunteering. I'm convinced that seniors who volunteer are healthier. So why not volunteer? Excuse me. And being active, being involved, and being connected is a deliberate choice as well. But we also, as a system, have to make that possible. So we have to create the kind of system and infrastructure that will incorporate people, that will allow people to be connected. And so I think ultimately the answer for what is it that we need to do is that we need to build on the things that are currently working, and we need to propose the kinds of solutions to government that are actually going to be workable. And to some extent, getting the attention of government between electoral cycles is a challenge. And part of the problem that we see is that there's a disconnection between the various ministers and ministries in order to come up with one plan that's going to work for everybody, because ultimately the minister responsible for seniors in Quebec has to talk to the healthcare minister. So that's a challenge, but it's a challenge that I think we're willing to take on. And I know that Ruth certainly has the energy to do it. So I want to pause right here and say a huge big thank you. The next slide that is up there has my email address on it. People can certainly contact me by email. I am very grateful for the fact that you were willing to listen to me this afternoon, and that you're involved in the process, because if all of us get involved, it's really going to make a difference. It's when we sit back and don't do anything other than complain that nothing much happens. So thank you very much, and I'm quite willing to take any questions that anybody would have. And I'm very grateful for the opportunity to actually chat with you and meet you all.
Sam, it's all our pleasure. It's great to meet you and have the opportunity to listen to you. And I was making a few notes, and I have one comment to make: no more Band-Aid solutions. We were talking about Band-Aid solutions back in the late 1960s in the anti-poverty movement. And it's time to move on, and I think we're a lot more aware, and we have the knowledge, the information, so let's move it forward. And I think you're 100% right. The one thing good about the pandemic is it certainly brought exposure to the needs and the challenges we're facing. It has put seniors' issues on the map, as well as many others, the housing and the homeless and whatnot. And I think most important is to remember that human touch and the extreme value it has, just to be able to talk to each other, see people, get a hug, get a handshake. I think it's so very important. I know you're pressed for time. We have about 10 minutes of, we could take some questions if Brendan has any, or I can just sit and talk back and forth with you, Sam. Brendan, do you have any questions?
None at the moment. But if we do encourage people to send them in if you haven't had a chance yet.
And I remind people that there will be a Survey Monkey that's going to come up on your chat box, so you can open it up and fill it. That would be very important for our funders. I've always been partial to seniors, probably because a grandmother raised me. And I worked in geriatrics at the Douglas. It was the Verdun Protestant, so I'm aging myself drastically. I find that there has been so little attention paid to the mental health, anxiety concerns of seniors. And now, it's your age, you didn't sleep well, you got arthritis, so you're going to be cranky, you're going to be down, it's going to get better, move on with it. But I think there's been some serious consequences of anxiety and depression where it's shown itself in over medicating, drinking on the sly, gambling. I know of cases in Outaouais, where the lady was at the video machines and almost lost the home, and the husband had no idea. He thought she was out volunteering every day. So there's all kinds of implications that is there, and nobody has really paid attention to it, and they are now starting. And I look at it almost as parallel to the homeless people. We always said, oh, well, they're lazy. Oh, they have some challenges. They don't want to work. Oh, they're into drinking. They're into the drugs. And that's not necessarily the case. They've been given a raw deal, some of them. Some of them are so disillusioned with society, they don't want to be implicated and involved with society. Have you seen some comparisons and some situations that are almost similar, Sam?
Oh, certainly. And not only that, you touched on something that maybe merits a little bit of an extra light. And that is, poverty is a robber. It removes a lot of things from an individual. So when somebody finds themselves experiencing poverty, it not only lowers your expected health outcomes, but it's removing a sense of dignity and agency from you. So you don't have the kind of choices that people like you and I feel we have. And the other thing that a robber, or if you think about your house being robbed, there's usually collateral damage. It affects other people. So when an individual, a family, a senior experiences poverty, there is a ripple effect that impacts other people. And so to the extent that we can begin to take steps that will alleviate poverty, that will at least lower the rate of poverty in Canada. Look, the good news is this: from 2015 to 2020, we lowered the poverty rate in Canada. It went down. So we can do this. We know what the levers are, and we just need to have the political courage to do some of those things that are absolutely necessary. And so when it comes to seniors, it's even more critical, because seniors are naturally going to have the potential to be alone, to be in situations where their income is reduced or restricted or stable. We always talk about that, a fixed income.
Yeah.
So to the extent that we can address that particular challenge, I think we're going to have that, what I call that elevator effect, where everything else goes up in the direction that you want it. Your health goes up, your sense of well-being goes up, your feelings about how you are and how life is goes up. And
that sense of belonging.
yeah, and this notion that I am not alone.
Yeah.
I think that's a very powerful sentiment, to know sort of I am not alone. I had both of my daughters move out last year, one of them to Quebec City, one of them to Ottawa. And one of the things that we dealt with these two 20-somethings was this profound sense of aloneness as they moved to new cities. And they're young and theoretically able to get out and do stuff. But so I saw this in younger people, and it occurred to me that the people we serve here at the mission who are older must be feeling a lot of that, and much more profoundly than they did. So I think that's an important thing, and we just need to focus the attention of our decision makers on that. So I'm seeing a question up here in the chat.
Yes, Brendan, there's one question that's come into you.
Yeah, I will read that. The question is, how can we as a community members make our voices heard with the government to put more money or spend it more wisely in the health system, keeping and retaining healthcare workers?
Well, look, I know that MNAs and MPs read their mail. So to the extent that you are contacting them and making your voice heard with them, I think that's critically important. And I also think providing support to agencies that amplify your voice. This particular organization is a voice amplifier. And so if you can make sure that you're part of organizations, or that you support organizations that are out there getting the job done, then it's one of the things that I say about people. If you're concerned about homelessness, don't go downtown and start handing out sandwiches. That's not helpful. But support organizations that are already on the ground getting the job done, because we know what needs to be done, we know where it needs to be done, and we know how it needs to be done. Trying to get something done entirely on your own isn't particularly helpful. So support those agencies that can amplify your voice, and then at the same time, don't hesitate to write to your MNA.
And just to add to that, Sam, if you go on the National Assembly website, you will see all the members of the National Assembly. You go on Ottawa's website, you will see all the members of Parliament. You can write to your own MP and MNA, but you can also write to the opposition critics, be it health, be it whatever, housing, and get your voices heard or your concerns heard.
Yeah, that works well, Ruth. Because it's funny, because I talk to all of the government ministers, but I also get the opposition critics. I had one in here earlier today who wanted me to help him craft a question that he's going to ask in the National Assembly next week. Now, of course, nobody's going to know that I helped craft the question, but it's, they come to us so that we can help them frame the question the right way and ask the minister and put them on the spot, which is kind of cool. So I even a couple of weeks ago helped frame a question for a Parti Québécois MNA who wanted to try to pin down Lionel Carman. And I thought, that's kind of cool, because I talk to Lionel Carman every week. But, here I am helping out the Parti Québécois critic to ask a question. So that's the sort of thing, the role that I'm lucky enough to be able to play. But I think all of the people on this call can play similar roles from whatever position you find yourself.
Yeah, there's nothing better than lobbying. I know, Sam, that you have to leave. You have to get to another municipality. I want to thank you ever so much. This has been most delightful, most informative, and I thank you for all the work you, your staff, and your volunteers at Welcome Home Mission are doing. I wish you continued success with it. And just to remind everybody to please do their survey. The next webinar we're having is October 17th, 10 to noon, and it's on tenants' rights, lease transfers, and if you have to move, what you should consider in advance to making a move. So I want to thank everybody. This will be available in about 3 to 4 days. It'll be uploaded on our social media, and it'll also be sent to everybody who registered. So thank you, Sam. Let you get on the road. I hope you don't
Thank you.
encounter traffic. And Brendan, thank you for all your technical support in the back, and everybody who attended. I appreciate it.
Thank you. Have a good weekend, everyone.
You too.